Okay. So today, good evening, everyone. Today, the class for discussion is amniotic fluid embolism. It is one important topic where none of the anesthesiologists nor the obstetrician likes to encounter in their lifetime because it is associated with greater degree of morbidity and mortality in a participant who is about to deliver or who is even in the first trimester or in the second trimester. See, amniotic fluid embolism is a very rare as well as it's a catastrophic condition, which is actually called a cytokine storm in pregnancy or an anaphylactic syndrome of pregnancy, where the antigen, which is inciting the factor, is not known, and it is commonly associated during labor and delivery for the delivering participants. And the incidence is somewhere around 1.9 to 6.1 cases per 1 lakh deliveries. And in varying studies, the reported incidence differs because of the inclusion criteria and the exclusion criteria, which is followed in each and every country which is reporting it. And there is also Amniotic Fluid Foundation and the Society of Fetal Maternal Medicine, which gives a diagnostic criteria. So in each country, they follow different criteria for guidelines of diagnosing the amniotic fluid embolism. And in UK, they have a specific registry for enrolling themselves into the amniotic fluid embolism registry. So the criteria for diagnosis differs from country to mortality of amniotic fluid embolism is close to 80%, and with the current increasing trend of treatment, which is advanced, as in case of any coagulation correction, as well as factor 7, or giving the patient ECMO or an exchange transfusion, because of these very many advanced factors which we have in hand right now to treat the coagulopathy or the inciting factor which would occur, we are having a very decreased mortality in the recent times. And the incidence, if at all, if it occurs, and the cause is really an amniotic fluid embolism, most of the patients have died within 2 hours or died within 5 hours of occurrence of symptoms. And those who are patients who live or survive to who have attained ROSC following a cardiopulmonary collapse, they will actually land up in a neurological sequelae or a acute kidney injury sequelae, wherein you have to treat them for the same. And the outcome depends on very many factors, which includes a team-based approach. And the diagnosis is exclusively a characteristic finding. It's a clinical diagnosis wherein it is made by a high degree of clinical suspicion. You have to have the characteristic finding of amniotic fluid embolism, and you have to have, there is no other that particular scenario. An occurrence of hypotension, like systolic blood pressure of less than 90 millimeters of mercury, wherein it is associated with respiratory symptoms like dyspnea, cyanosis, desaturation, less than 90% in room air. All these, there should be a International Society of Thrombosis have the score of more than 3, wherein platelet count is taken as one parameter, PTINR is taken as other parameter, fibrinogen level is taken as other parameters, score for normal patients as well as score for pregnant patients, wherein the D-dimer will not be included in pregnant patients. So the score modified for pregnancy should be taken, and the score should be more than 3 in an acute onset. And this should happen when there is a clinical onset during labor or within 30 minutes of any placental delivery, may it be a cesarean section or vaginal delivery. So it should occur during labor or during the 30 minutes of delivery, and there should be absence of fever during the labor. If there is fever during the labor, it will point more towards sepsis and septic shock. Sepsis and septic shock or any other feature which may be present. And the risk factors may be advanced age, patient being multiparous or tumultuous, and those who are experiencing preeclampsia or eclampsia. Any placental abnormalities, may be abruption or increta or accreta. All those things can lead to a increased risk of amniotic fluid embolism. And it was said that previously they used to use amnio infusion in Western countries, and they used to monitor the intrauterine pressure by an intrauterine pressure catheter. So at that point of time, you may actually sedil the amniotic fluid contents from the mother to the fetus, and that can incite a amniotic fluid embolism scenario. Though this is not routinely practiced in our part of the country, it has been practiced in West. And cesarean delivery, there are anecdotal data which says cesarean delivery is associated with increased risk of amniotic fluid embolism. However, recent studies does not prove the same. And instrumental vaginal deliveries, wherein cervical tears or vaginal laceration can give away the amniotic fluid contents into the maternal circulation. And the cervical laceration, whenever there following a vaginal delivery, that also can cause a increased risk factor for amniotic fluid embolism. So the pathogenesis revolves around amniotic fluid, though this is not being the exact pathogenesis or exact molecule which incites the amniotic fluid mechanism embolism is not still diagnosed, but it is an anaphylactoid syndrome of pregnancy, which is thought to be due to the entry of amniotic fluid and its contents, which may contain mucin, fetal urine, or fetal meconium contents, that entering into the bloodstream has been proposed as the proposed mechanism of action. And there are 3 phases which is given in Schneider, especially for these amniotic fluid embolism, which is phase 1, which is characterized with the cardiovascular or respiratory collapse, and phase 2, as and when you resuscitate the patient for cardiorespiratory arrest, the patient may land up in coagulopathy. And in phase 3, even if the ROSC is achieved, the patient may land up in non-cardiogenic pulmonary edema and acute kidney injury. So the timing of occurrence will actually be in correlation with the placental separation or any placental handling, wherein it can come from, there are case reports where they have actually removed the cervical encerclage. So at that time also, the amniotic fluid embolism can occur. And tear from the endocervical veins whenever you are doing an instrumental delivery, or when you are giving an intrauterine pressure catheter, or if you are doing an amniocentesis from outside, or when there is a placental separation like abruption, or when you are doing a cesarean delivery wherein you are having a placental issue, at that point of time also this can occur. So the pathogenesis essentially revolves around the entry of amniotic fluid and its contents with mucin and all sorts of porphyrin contents into the maternal circulation, and that leads to the abnormal activation of humoral as well as the immunological factors, which will trigger the vasoactive and the procoagulant substances, leading to a syndrome which resembles the systemic inflammatory response syndrome. So these maternal amniotic fluid entering into the maternal circulation from either a ruptured vessel in the intrauterine cavity, or it can actually hugely form embolus itself and migrate into the systemic veins and cause a pulmonary thromboembolism. So this incites a maternal anaphylactoid reaction, which activates the pulmonary vasospasm as well as bronchospasm, and a coagulation cascade, which will result in disseminated intravascular coagulation. So since these material also in the myometrium can cause a local inflammatory reaction that can lead to uterine atony and hemorrhage to follow. Since because there is pulmonary artery vasospasm, it will lead to pulmonary artery hypertension, later leading on to other cardiovascular symptomatology which will take place. So in cardiovascular symptoms which the patient will present with, one thing is sudden hypotension and arrest. Whenever a patient in labor or during cesarean delivery arrests without any premonitory symptoms like just restlessness and arrest, one differential diagnosis to note for is either an acute pulmonary embolism or an amniotic fluid embolism. All those 5H and 4Ts will follow, but during cesarean delivery, as and when the placenta delivery occurs, or in a labor natural, whenever you are giving an epidural bolus, or when the patient is about to deliver, sudden restlessness and arrest, one important differential diagnosis is amniotic fluid embolism. So what will happen is when there is a sudden insurge of contents from the amniotic fluid,